Hello everyone, this is JJ from Radiotech Academy. In today's video, we're jumping into one of the most important topics in medical imaging: radiation protection. Up to this point, you've learned how an X-ray tube works, what happens when radiation interacts with the human body, what kinds of damage it can cause, and which of those damages the body can or cannot repair. Today we're going to take all of that knowledge and turn it into practical, real-world tips that can help protect your health, whether you're a patient, an engineer, or a radiology technician. I've broken everything down in a simple, clear, and easy-to-understand way, so even beginners can use this information to protect themselves and their families. So stay with me until the end of the video, and if you haven't subscribed yet, make sure to hit that subscribe button so you don't miss any of the upcoming videos. Alright, let's get started. Ionizing radiation, like X-rays and gamma rays, are incredibly powerful tools in both diagnosis and treatment. With these types of radiation, we can detect diseases more accurately and even treat certain conditions. But if they're not used properly, they can cause side effects. Some of these effects are short-term, such as erythema, which simply means redness of the skin, or even burns when the dose gets very high. We also have long-term effects to consider. These can include an increased risk of cancer, the development of cataracts, impacts on reproductive ability, and several other health issues. And this is exactly where radiation protection becomes important. The main goal is to keep all the clinical benefits of radiology equipment while minimizing the unavoidable risks as much as possible. One of the most important principles in radiation protection is the concept of ALARA. This English term stands for as low as reasonably achievable. The idea is to reduce any radiation dose entering the body as much as is technically, economically, and practically reasonable. It doesn't mean trying to reduce the dose to zero. Instead, the goal is realistic, practical, and well-documented optimization. In practice, ALARA comes down to making a series of thoughtful, informed decisions. Is the imaging study truly necessary? Which technical settings can give us the lowest possible dose while still keeping the image quality good enough for diagnosis? And what equipment or team behaviors can help reduce the dose even further? Organizations like the IAEA, the International Atomic Energy Agency, and the CDC have published detailed guidelines on how to apply ALARA. They all highlight 3 essential actions for reducing radiation dose: time, distance, and shielding. In simple terms, the shorter the exposure time, the greater the distance from the source, and the more protective shielding we use, the lower the dose we receive. Time, distance, and shielding. This section may be short, but it's one of the most important foundations in radiology. Almost everything we do in this field is built on these 3 principles. 1. Time. Technical reason. Effective dose equals dose rate multiplied by exposure time. In simple terms, the longer you stay inside the radiation field, the higher your total dose will be. So, any reduction in exposure time directly lowers the dose you receive. In practice, in fluoroscopy systems, always use pulsed fluoroscopy instead of continuous mode. Also make use of the last image hold feature, which lets you view the final stored image without generating any new radiation. Studies, including reports from professional journals like AJR, have shown that switching from continuous fluoroscopy to pulsed mode combined with last image hold can significantly reduce the total dose. 2. Distance. Technical reason. There is an extremely important rule in radiation physics called the inverse square law. This law says that radiation intensity is proportional to 1 divided by the square of the distance. So if you double your distance from the source, the intensity, and therefore the dose, becomes 1/4. A simple numerical example. Imagine that at a distance of 0.5 meters from a radiation source, the dose rate is 4 microsieverts per hour. If we increase that distance to 1 meter, exactly double, the dose rate becomes According to the inverse square law, we take 4 microsieverts multiplied by 0.5 divided by 1, and then squared. 4 microsieverts multiplied by 0.25 equals 1 microsievert per hour. So doubling the distance reduces the dose to 1/4. The takeaway? Even taking one single step back can significantly reduce your exposure. In practice, the design of radiology rooms, the positioning of technologists during procedures, and the use of remote controls are all based on this principle. These rooms are arranged so that even shifting your position by just a few steps can noticeably lower the dose you receive. 3. Shielding. Technical reason. Dense materials, such as lead antimony compounds, and lead-based polymers, have the ability to absorb or scatter X-ray photons. Because of this property, they help reduce both primary radiation and scattered radiation. In practice, lead aprons, thyroid shields, leaded glasses, and lead-lined windows and walls are all built with a specific amount of lead equivalence Pb, and each one must be used in the correct location to provide proper protection. But there's an even more important point. The condition and performance of shielding must be checked regularly. Cracks, tears, or even small holes can drastically reduce how effective the protection is. The International Atomic Energy Agency has also published detailed guidelines on how to select shielding equipment, how to maintain it, and how often it should be inspected. Now, in this section, we're going to talk about the most important protective shields used in radiology and fluoroscopy, what features they offer, how they should be selected, and what maintenance steps really matter. These shields are a major part of radiation protection, and if they aren't used or maintained correctly, their real effectiveness can end up being much lower than what we expect. A lead apron. The lead apron is considered the most important personal protective device in the radiology department. Lead equivalents. Lead aprons are usually manufactured with 0.25, 0.35, or 0.5 millimeters of lead equivalents. Recent studies, including articles published on Science Direct, show that in many interventional procedures, a 0.35 millimeters lead apron performs almost as well as a 0.5 millimeters apron, while being lighter and causing less fatigue for staff. However, the final choice always depends on the type of procedure, the equipment used, departmental protocols, and local regulations. Practical usage notes. The apron must be worn fully and correctly. You should avoid folding, bending, or overlapping its edges, because these actions can create internal cracks in the protective layers. Visual and physical inspection at least every 6 months, or according to hospital policy, is essential. Many centers use AP radiography or special fluoroscopic apron testing to detect damaged areas. The apron must be stored on a proper, flat, standard hanger, and no sharp objects should ever be placed on it. Thyroid shield. The thyroid gland is one of the most radiation-sensitive tissues in the body. During fluoroscopy, and even in regular radiographic exams performed near the neck, using a thyroid shield with at least 0.5 millimeters lead equivalents is absolutely essential. This small device can significantly reduce the dose absorbed by the thyroid, and it should never be forgotten. Lead glasses, the lenses of the eyes, especially during long fluoroscopy procedures, are vulnerable to radiation, and the risk of radiation-induced cataracts is taken very seriously. Because of this, international organizations such as the International Commission on Radiological Protection (ICRP) have lowered the allowable dose limit for the lens of the eye. Using lead glasses with at least 0.5 millimeters lead equivalents can substantially reduce the radiation dose reaching the lenses and help protect your vision over the long term. Lead gloves and extremity protection. Whenever the hands need to be close to the radiation field, for example when holding instruments during a procedure, using lead gloves or holding tools becomes necessary. However, here's a very important reminder. Wearing lead gloves does not give you permission to place your hand in the primary beam. The primary beam delivers extremely high dose, and the correct approach is always to use tools, increase distance, and avoid putting your hands directly into the beam under any circumstances. Environmental shields, mobile shields, ceiling suspended shields, protective glass. In long procedures such as angiography, using suspended shields or leaded glass placed between the patient and the operator is extremely effective. The room should be arranged so that the operator can move comfortably behind these shields while staying fully protected. These environmental shields are especially good at reducing scattered radiation, which is a major source of exposure for staff. Maintenance and quality control policies. All protective shields must have records of periodic inspections, damage reports, maintenance history, and replacement schedules. In many centers, when purchasing new shielding equipment, service contracts and periodic testing agreements are made with the manufacturer to ensure the shields continue to perform effectively. International organizations such as the ICRP and the IAEA have published detailed guidelines covering the selection, maintenance, and evaluation of shields to make sure they meet safety standards. Now let's move into one of the most important aspects of radiation protection: occupational monitoring. If we want to know exactly how much radiation a technician or physician has received, the only reliable tool is a dosimeter. No guessing, no estimates, only actual measurement can tell us the truth. Why is occupational monitoring so vital? Continuous monitoring and recording of dose, also called dosimetry, is the only precise way to show how much radiation staff members have truly been exposed to. Dosimeter data is not just a simple number, it is essential for trend analysis, tracking dose over time, identifying hotspots, places or procedures with higher exposure, protocol adjustments, optimizing procedures for safety, reviewing behaviors and work patterns, seeing how staff habits affect dose, providing feedback to the team, improving awareness and safety. When this data is properly recorded and analyzed, it can transform the safety culture of the department. Now, let's get a bit more practical. Whether you work in CT, fluoroscopy, or even the operating room with a C-arm, there's one thing you always carry: a personal dosimeter. These dosimeters are usually TLD or OSL types and work like a radiation exposure diary. Whenever radiation you receive throughout the month, this small device records it. But here's the important point. Using a dosimeter is not just about wearing it. There's a complete process. At the end of each month or monitoring period, the hospital or clinic collects the dosimeters from staff and sends them to a specialized company or center. These centers use precise equipment to read the dosimeters and measure, according to international standards, exactly how much ionizing radiation you were exposed to that month. After the dosimeter is read, an official report is generated showing exactly monthly total dose, annual cumulative dose, comparison with the allowable dose limit, trends compared to previous months. This information is extremely important. If your dose exceeds acceptable limits, the cause must be identified. For example, was the shielding defective? Was the equipment producing excessive scatter? Was the fluoroscopy time too long? Once the cause is known, serious occupational safety measures must be implemented. In some centers around the world, if a technician's dose rises, their shift may be changed. They may be removed from the radiation environment for a period, or they may attend a radiation protection retraining course. The goal is clear: no one should approach the annual dose limit. We don't want to wait until the limit is reached to discover there's a problem. Many students or novice technicians think that high doses happen only for those working with heavy equipment like fluoroscopy. But in reality, anyone in a radiation environment needs to know their dose. Even in simple radiology, if radiation behavior isn't correct or the device isn't properly collimated, unexpected doses can occur. Now that we've fully covered monitoring, it's time to move to a very important question. What is the actual dose limit? When is a dose too high? And how much dose does each department typically receive? To make this topic simple, precise, and easy to understand, I've prepared 3 very important and practical tables for you. Alright friends, now let's take a look at Table 1. This table shows the standard occupational dose limits defined by the ICRP and IAEA. These numbers are safety boundaries, not targets, which means our goal is to stay well below them at all times. Here's a breakdown. Whole body effective dose. The dose received by the entire body is 20 millisieverts per year, averaged over 5 years. In special cases, the maximum annual dose can go up to 50 millisieverts. Eye lens dose. The annual limit is 20 millisieverts. Skin and extremities. The annual limit is much higher, at 500 millisieverts. Fetus of pregnant workers. The maximum dose for the entire pregnancy is only 1 millisievert. So as you can see, this table shows the limits for different tissues and body parts, and the main goal is to make sure we never come close to these boundaries. Here's a quick overview. General radiology, 0.3 to 1.5 millisieverts per year. Exposure is low here because most of the work can be controlled from the operator room. CT scan, 0.5 to 4 millisieverts per year. The exact dose depends on whether the technician needs to enter the room during the scan. Mammography, 0.1 to 5 millisieverts per year. Very low exposure. Uroscopy, C-arm, and angiography. This is where highest occupational exposure occurs, with doses between 2 and 15 millisieverts per year, depending on procedures. Radiotherapy, usually safe, around 0.2 to 1 millisievert per year. Dental radiology, the lowest exposure, typically 0.1 to 0.3 millisieverts per year. So, this table clearly shows where higher doses are likely, helping staff understand which departments require extra attention and careful radiation protection. Now let's look at Table 3. This table shows the recommended maximum working duration before your dose approaches warning levels. It's not an official table, but it's very practical and educational, helping you understand how often you should seriously check your dose in each department. Here's a quick summary. General radiology. Average annual dose is about 1 millisievert. Staff are generally safe for almost the whole year, so regular dose checks can be done once a year. CT scan average annual dose is around 3 millisieverts. Serious dose checks are recommended every 3 to 4 months. Mammography average annual dose is about 0.3 millisieverts, so there's no special concern. Light fluoroscopy dose is higher, around 6 to 8 millisieverts per year. Staff should perform serious dose checks every 2 to 3 months. TLD, thermoluminescent dosimeters. These thermal dosimeters are used for periodic readings. They are highly accurate and have been the standard in many centers for years. Staff wear them for a monitoring period, and the readings are then processed to determine the cumulative dose. OSL, optically stimulated luminescence dosimeters. This type is highly accurate and one of the most commonly used tools for staff monitoring today. OSL dosimeters are convenient and can provide precise measurements over longer periods. EPD, electronic percentile dosimeters. These electronic dosimeters provide real-time readings and audible visual alarms if dose rates are high. They are particularly suitable for environments where immediate monitoring is critical, such as fluoroscopy or interventional procedures. Ring dosimeters. These small devices are designed to measure hand doses, especially during interventional procedures, where the hands are close to the radiation field. Older or legacy dosimeter. Some dosimeters, such as film badges, were widely used in the past. They worked by exposing photographic film to radiation, which could then be developed to estimate dose. While historically important, these are rarely used today due to lower sensitivity and slower processing compared to modern TLD, OSL, and electronic dosimeters. Proper placement and wearing of dosimeter. Single dosimeter. Synodasic setup. A dosimeter should be worn on the collar, outside the lead apron. This placement gives the best estimate of exposure to the head, neck, and eyes. 2 dosimeters. Protocol for interventional procedures. For long procedures such as angiography, wearing 2 dosimeters is standard. 1. Outside the apron on the collar, monitors head and neck dose. 2. Under the apron, estimates the whole body effective dose. This dual setup gives a more accurate picture of staff exposure. Ring dosimeter. This should be worn on the second or third finger, the one usually closest to the beam, to accurately track hand dose. Reading, recording, and follow-up. Dosimeter readings are usually reported monthly or quarterly. When reviewing these reports, there are several key points to keep in mind. Watch for unusual increases. Gradual increases in dose may indicate changes in work habits such as longer fluoroscopy times, changes in equipment setup, reduced adherence to distance and shielding principles. If an individual's dose suddenly rises, immediate investigation is required. Review the procedure carefully. Check all protective shields. Analyze the fluoroscopy films. Identify possible user errors, or determine if retraining is needed. Communication with staff and team feedback. Periodic feedback meetings such as monthly sessions are extremely valuable. When each staff member's dose trends are displayed as charts, it helps increase acceptance of corrective behaviors, motivate staff to consistently follow radiation protection principles. By making dose trends transparent and actionable, departments can strengthen their safety culture and ensure everyone stays protected. Policies and principles for proper dosimeter use. To ensure accurate dose monitoring, dosimeters must be used properly. Never keep a dosimeter in a pocket or exchange it with another staff member. Staff should know exactly what to do if a dosimeter is forgotten, lost, or damaged. Outside working hours, dosimeters should be stored in a safe, protected location, away from any fixed radiation sources, to maintain accurate readings. Following these simple rules ensures that the recorded dose reflects actual exposure and helps maintain staff safety. International standards for monitoring and dose determination, occupational radiation monitoring, and dose limits are defined by international organizations such as the IAEA, International Atomic Energy Agency. ALARA in practice, CT and fluoroscopy scenarios. This section focuses on practical radiation protection, especially in fluoroscopy, where staff usually receive the highest occupational exposure. ALARA in CT. In CT scans, most radiation affects the patient, and staff usually leave the room during scanning. However, staff may need to stay in the room for tasks such as patient positioning or manual contrast injection. In these cases, prepare all equipment in advance. Ensure all tools and positioning devices are ready to minimize time in the room. Use mechanical tools or holders. These help stabilize the patient without needing to be close to the radiation source. If you must stay in the room, always wear a lead apron, thyroid shield, and dosimeter. Optimization in CT. To reduce dose while maintaining image quality. Adjust technical settings like KVP, MA, pitch, and collimation, based on diagnostic needs. Many modern CT protocols include automatic dose modulation, where the system adjusts the MA according to patient thickness, helping reduce overall radiation exposure. ALARA in fluoroscopy. Here are practical tips to reduce radiation exposure for staff and patients during fluoroscopy procedures. 1. Use pulsed fluoroscopy. Pulsed mode reduces the frame rate, 7.5, 15, or 30 fps. Always select the lowest frame rate that still gives good image quality. Studies show pulsed fluoroscopy significantly reduces patient and staff doses. 2. Use last image hold. After stopping the beam, the monitor keeps the last image displayed. Physicians can review the image and plan the next step without more radiation. This is especially useful for teaching and real-time decision-making. 3. Precise collimation. The smaller the radiation field, patient dose decreases. Scatter radiation is reduced. Staff dose decreases. Always collimate to the smallest necessary field. Proper positioning and collimation are critical skills. 4. X-ray tube and detector position. If the tube is close to the patient, the field is smaller, but scatter usually increases toward the operator, especially if the tube is above the patient. Recommended standard: tube under the patient, under table to direct less scatter towards staff. 5. Use ceiling suspended and table side shields. Whenever possible, use ceiling suspended shields or leaded glass. Provides maximum protection for the head, eyes, and neck. 6. Operator distance and positioning. Based on the inverse square law, even a few centimeters increase in distance can dramatically reduce dose. Practical tip: stepping back, one step can reduce dose by 30–50% in many cases. 7. Use holding tools. Avoid putting hands in the primary beam. Always use clamps, holders, or stabilizing devices instead. 10. Team and periodic practice. Dose reduction is a team effort. Practice optimization techniques in training sessions, simulations, and monthly reviews. Better coordination reduces fluoroscopy time and minimizes positioning errors. Pregnant staff considerations. The fetus is highly sensitive to radiation, especially in the early stages of pregnancy. Extra precautions are required, including limiting exposure to well below standard occupational limits, using protective shielding, such as lead aprons specifically designed for pregnant staff, reevaluating duties if a role involves frequent close contact with the radiation field. Workplace policies. Departments should have clear protocols for monitoring staff doses, assigning duties, and ensuring proper use of shielding. Education and training must emphasize ALARA principles, proper dosimeter use, and periodic review of exposures. Maintaining a safety culture ensures that staff can perform their duties while keeping radiation risks minimized for everyone. Protecting expectant employees. Protecting pregnant staff is one of the most sensitive and important aspects of radiation safety. As soon as an employee learns they are pregnant, they should confidentially inform the Radiation Safety Officer (RSO). This is not for restriction or punishment, but to ensure appropriate limits and risk reduction. Key points. Fetal dose. The recommended maximum dose for the entire pregnancy is generally below 1 millisievert. This may vary slightly depending on national regulations. To achieve this, pregnant staff are usually kept away from high scatter procedures, such as interventional work or prolonged fluoroscopy. Task reassignment. Departments often reassign duties so pregnant staff work in areas with minimal or no radiation exposure. If presence in a procedure is unavoidable, detailed fetal dose calculations are performed. Dose reduction strategies are applied, including proper use of lead shields, minimizing time in the radiation field, standing at a greater distance from the radiation source. Takeaway: education and proactive planning are essential. By anticipating exposure and following protective measures, pregnant staff can safely continue to work without unnecessary risk to themselves or the fetus. Frequent mistakes and their impact. 1. Forgetting the dosimeter or keeping it in a pocket. When the dosimeter is not worn properly, all essential dose monitoring data is lost, which increases the risk of unrecorded and unknown radiation exposure. 2. Using a damaged lead apron. Cracks, tears, or tiny holes in the lead layer significantly reduce protection. Damaged aprons should be immediately removed and replaced. 3. Standing too close to the patient during fluoroscopy without proper shielding. This is a major cause of increased staff dose. Even stepping back a few steps or using a ceiling suspended shield can make a noticeable difference. 4. Not using pulsed fluoroscopy, last image hold, or proper collimation. These 3 tools are the pillars of dose reduction in fluoroscopy. Ignoring them unnecessarily increases the dose for both patients and staff. 4. Folding the lead apron or placing it on the floor. Such handling can cause internal breaks in the lead layers, reducing protection. Aprons should always be hung on the designated rack. Real-life scenarios. Scenario A. Long angiography procedure. During a long procedure, one operator stayed close for convenience. However, by correctly adjusting the sealing shield, keeping distance, and using a lower frame rate, the dose was controlled. At the end of the month, the dosimeter report confirmed that exposure remained within safe limits. This highlights that teamwork and strict adherence to radiation protection principles are effective, even in demanding procedures. Scenario B. Quick procedure without proper collimation. Even a short fluoroscopy session can be risky if the radiation field is not collimated. Scatter increased, and nearby staff received higher doses than expected. This led to a protocol review and additional training, emphasizing the importance of proper technique. Conclusion. Key messages. ALARA means active optimization. Don't fear radiation, and don't ignore it. The goal is to use it safely and scientifically. The 3 golden principles always apply: minimize time, maximize distance, and use proper shielding. Dosimeter monitoring is essential. It is the only reliable method to know actual exposure. Never forget your dosimeter or exchange it with others. Fluoroscopy is the highest risk environment. Using pulsed mode, collimation, proper distance, and sealing shields can significantly reduce staff dose. Protect your eyes. Always wear lead glasses and use appropriate shielding. Alright guys, that's a wrap for today's session. I truly hope you enjoyed this video, and from the bottom of my heart, I wish you all good health. No matter which department you work in, radiology, fluoroscopy, CT, or anywhere else, if you follow the tips we covered today, you can protect your health as a valuable asset. As I mentioned earlier, X-rays are a double-edged sword. They can be extremely useful, but if safety rules aren't followed, they can be harmful. So take these points seriously and keep them in mind at all times. Finally, a few important reminders. If you found this video helpful, like it. If you think your friends or colleagues could benefit, share it with them. And most importantly, subscribe to the channel. Your subscription is my biggest motivation to make more videos with even better energy and quality. Thank you for watching. Take care of yourselves, and I'll see you in the next video.